Associate Professor Jamus Lim.
Mr. Speaker, the proposed amendments to the Healthcare Services Act is part of a multi-year rollout of reforms to healthcare services that aims to bring healthcare governance into the 21st century. As the healthcare services, as well as their mode of delivery, have advanced, it has become necessary to refine regulation in the sector. The bill being debated today implements additional enhancements based on feedback in consultation with stakeholders since Phase 1 was rolled out, while also accommodating recent changes to the face of healthcare services delivery, especially over the past few years. All these are unobjectionable, and for this reason, the Workers' Party supports the bill. The first part of my speech will sketch out some residual concerns. The second part briefly asks about the future of healthcare services provision and what it may be for non-doctor medical professionals. Clauses 2 and 3 of the bill, as well as sections 3 and 8 of the original act, refine the definition of service facilities so as to weave in the possibility of remote healthcare provision, such as via the internet or telephone. Telecare, telehealth, or telemedicine have suddenly come into their own due to the enforced isolation practices necessitated by the pandemic. Given the confusing jumble of possible terms in this emerging field, it's natural to ask if the language in the legislation is sufficiently encompassing, or in this case, excessively accommodating. After all, how does defining service delivery mode to include, and I quote, A, at permanent premises, and B, at any premises other than permanent premises, lend guidance as to the sort of location that a licensable healthcare service may be provided from? I can guess at the motivation behind why Clause 2FB was inserted, but it still strikes me as so universal as to lend no additional constraints at all. Related to this issue of location is the fact that the Healthcare Services Act is not extraterritorial in nature. I understand why imposing our domestic service delivery standards on other jurisdictions is essentially untenable. But given how it's not only possible but increasingly likely that the healthcare services value chain becomes ever more internationalized, think of the proverbial radiographer based in Bangalore, or for that matter, an AI system with servers located in Iceland, coded by programmers in India, and consulted by scientists in Israel. What sort of regulatory mechanisms are in place to protect patients in Singapore from potential safety failures by foreign providers? Now, the new Section 31 of the bill deals with advertising. Much of this is commonsensical. Section A prohibits marketing of the treatment of a medical condition by unlicensed healthcare service providers, and Section B restricts the use of the term doctor in healthcare advertising. The concern here is whether these restrictions would rule otherwise legitimate medical providers. Non-Western healthcare providers naturally come to mind. I understand that practitioners of traditional Chinese medicine, or TCM, do fall within the domain of specified persons, but this still raises two separate issues. First, as far as I'm aware, Ayurvedic, Siddha, and Jamus practices are not included in this list. Does this bill then preclude their ability to advertise their services? Is the reason why these groups are not included as specified persons because they do not have official oversight boards? If so, is this sufficient justification for the exclusion, given how they simply lack the critical mass to justify a societal body? Second, the qualifications required for different accreditation bodies are actually disparate. More specifically, each group often may impose different standards of rigor insofar as qualification benchmarks are concerned. This applies not only to this bill, but also what a suitably qualified individual means in the original act. Local midwives, for instance, do not appear to distinguish between different levels, compared to as many as 5 in jurisdictions such as the United States. Qualifications within nursing, likewise, have only recently become more differentiated. Advanced practice nurses, senior nurses who possess advanced training and can take on some roles in diagnosis and treatment date back to only 2006, and currently only 57 are licensed to prescribe medicine. Singapore only recognizes 2 categories of TCM practitioners, and for one of these, acupuncture, registration is currently only open to qualified registered doctors and dentists. Compare these to the wide range of degrees, subspecializations, and levels that exist already for doctors. This naturally begs the question of whether the rigor associated with classifying these different tiers of medical practices are equivalent. And if not, what does this mean for their credibility when it comes to advertising? Now, to be clear, I'm not suggesting that these other traditional medical practices be accorded the same sort of recognition as modern medicine, or that their advertising should not be regulated in some form. Still, it remains unclear to me why non-TCM groups should be prohibited from marketing their offerings. Conversely, I'm left wondering if the qualifications embodied in advertising by the different types of medical professionals are truly comparable. Perhaps a compromise would be to require an additional disclaimer applicable to non-Western medical practices be included in all advertising efforts from this group. Now, this notion of differing tiers of medical practitioners, as well as the stress in Section 31B about the use of the term doctor, sparks a more general query. What steps has the ministry undertaken to fill the niches that currently exist in our healthcare service providers? This is especially pertinent given the lower coverage of both doctors and nurses in our population. The latest available data, which applies to 2016, for example, indicates that Singapore has 2.3 physicians per 1,000 people, a little higher than the world average of 1.7, but substantially below the OECD average of 3.8. It is also pertinent in the light of how our current slate of medical professionals are reportedly burning out, a bipartisan concern that has been raised in this House by, among others, my honourable friend, Ms. Herting Roo, as well as the honourable member who just spoke, Mr. Louis Ng. I understand that there are plans to increase the number of advanced practice nurses able to prescribe medication to 700. This is important and will provide some relief to our overworked doctors and fill in the gaps in healthcare services provision for our aging population. But what about the other tiers within the nursing profession? Has each tier been filled to an extent that would offer relief down the pipeline of medical professionals? What about increasing the number of recognized universities for basic medical degrees? The list of registrable medical qualifications only numbers to 100. While a few additions have been made in recent years, these are only a small handful. It's hard to conceive of how a country like France, with a population and medical school count almost 3 times that of Australia, has only 1 lonely university on the list versus Australia's 8. Similarly, I fail to understand how Japan, a country ranked first in at least 1 global index of health systems ranking, has only 3 of the country's 80 medical schools on the list. So the bottom line is that as much as we focus on legislative refinements, the quality of our health services will ultimately be determined by our ability to ensure that there is adequate supply of healthcare workers at all levels. This extends from the best doctors we're able to attract from around the world to the invaluable community health workers that render so much of the behind-the-scenes support to every other role in between.